Good afternoon, ladies and gentlemen. Today I will present the research of the index and invasive fungal infection in adult AML with first episodes of febrile neutropenia. AML is the most common form of acute leukemia in adults, with treatment of high-intensity chemotherapy resulting in 60% cure. However, severe neutropenia with neutropenic fever or febrile neutropenia occurs in almost patients who receive the treatment. Moreover, neutropenia is strongly considered as the major risk factor for developing invasive fungal infections or IFIs. The duration of neutropenia lower than 500 or grateful neutropenia and lower than 100 or so-called profound neutropenia are associated to IFIs. However, using only duration but not the depth of neutrophil counts may lack of ability to accurately determine the IFIs. For these reasons, an alternative assessment of neutropenic burden by using both of intensity and duration of neutropenia called the index has been developed. There were several studies of the index and cumulative the index predominated in AML patients who received high-intensity chemotherapy and allogeneic stem cell transplants. To calculate this index, we used the cumulative area of trapezoidal shape in the area above of neutrophil curve based on serial data of complete blood count as starting point from ANC lower than 500 to ANC recovery. For the cumulative D-index or C-index, starting point is the same, but the finishing time point is the first manifestations of neutropenia-related complication, for example, clinically suspected IFI or first peak of fever. The previous studies for predicting IFIs by using the index in ML patients show high negative predictive value with the various cutoff. However, the prevalence of IFIs in the previous study were less than 10%, which is different from Thai AML patients with 10 to 20% prevalence. So, this study aimed to determine the performance and the optimal cutoff of the index in Thai patients with AML and compare to the duration of neutropenia in predicting IFIs. This was a retrospective cohort included adult AML who received standard serenity induction and developed febrile neutropenia with adequate serial complete blood count data until ANC recovery. AML patients who didn't receive 7+T or refractory to 7+T were excluded. Patients without ANC recovery after treatment or had an IFI before were also excluded, and APL was also not permitted into the study. Antimicrobial use in the study in terms of prophylaxis, fluoroquinolone was not routinely prescribed. Itraconazole and acyclovir were used as the antifungal and anti-herpes prophylaxis. Treatment of febrile neutropenia included empirical broad-spectrum antibiotics, amphotericin B for clinically suspect IFI, and voriconazole for documented IFIs according to the EORTC guideline. The primary outcome was the sensitivity of the index in predicting IFIs. At least of 100 patients should be low to determine the adequate sensitivity. For the results, over of 200 AML patients were recruited and 101 patients met the inclusion criteria, which is divided into AML with IFI in 16 and without IFI of the 85. Here is the baseline characteristic between patients with and without IFI, which is a similarity. An average age about 40 years old with equal distribution between sex was shown. All patients received itraconazole for fungal prophylaxis. There was no difference between cytogenetic risk groups. For IFIs, almost 90% were invasive primary aspergillosis, and other infections were similar between groups. For neutropenia, the index and cumulative synergic between groups, GCSF was used significantly higher in IFIs, as well as the durations of grateful neutropenia and profound neutropenia compared to the patient without IFIs. Moreover, both of D-index and CD-index were significantly higher too. To compare the performance between the index and the duration of neutropenia in predicting IFIs, the ROC curve analysis was performed. The index showed a better discrimination than both of duration of graceful neutropenia and profound neutropenia, as same as CD index, which is outperformed the graceful neutropenia duration but not differ from profound neutropenia. To determine the optimal cutoff of the index with the prevalence of IFI of 15.8% in this study, about 7,000 of the index and 5,600 for CD index were selected. The sensitivity of the index was 81.3% and 68.8% for CD index. Over 90% of negative predictive value was shown in both indexes. Below this cutoff, patients without IFIs were overtreated in more than 50% of patients. To the best of our knowledge, this was the first study of the index utility in Thailand. AML with IFI has longer neutropenic duration and higher D index. Moreover, both of indexes outperform the neutropenic duration for predicting IFI. With a cutoff of 7,000 in D index and 5,600 in CD index, the negative predictive value over 90% was shown in the background of IFI prevalence of 15.8% in this study. These results potentially exploit to exclude IFI if the patients had this index below the particular cutoff. Compared to the previous study, which is small-scale sample size and low incidence of ISI, this study has larger in-study population with the context of higher prevalence of IFIs. Interestingly, there was an RCT using the index-guided antifungal therapy versus empirical antifungal therapy in the prevalence of IFI about 2%. This study decreased in using of antifungal from 60% to 30% without increase of fungal infection. There were several limitations to be addressed. First, the specific group of the first episode febrile neutropenia make this study less generalizable to other populations with different treatment. The refractory cases and patients without ANC recovery were also another limitation for using the index. Moreover, the retrospective nature in this study make the missing data and some of selection bias inevitable. This study also, based on single center, which is the policy on antimicrobial use, may differ from other centers. In conclusion, the index and CD index were first demonstrated here about the performance in predicting IFI in Thai AML patients. Thank you for your attention.